I published two reports recently with the same title, Build Back Fairer. The one in December 2020 was for England. The one in March 2021 was for the so-called Eastern Mediterranean region of the World Health Organization, North Africa and the Middle East. But in both cases, the idea was that as we emerge from the pandemic, we should not want to be re-establishing the status quo of how we were before the pandemic. We need to build back fairer. My book, The Health Gap, began with this line: why treat people and send them back to the conditions that made them sick? Particularly in a pandemic, we're conscious of how important the health care system is. But I'm talking not about health care, but about health, about the social determinants of health, the conditions that make people sick in the first place. In February last year, I've already mentioned a report I published in December, but 10 months earlier, in February 2020, I published a report, Health Equity in England, the Marmot Review 10 years on. Now, I have to go back 2 steps to put that in context. I chaired something called the Commission on Social Determinants of Health for the World Health Organization. What are social determinants of health? We said they're the conditions in which people are born, grow, live, work, and age, and inequities in power, money, and resources that give rise to inequities in the conditions of daily life. That was a global commission published by the World Health Organization, and the then Prime Minister of the UK, Gordon Brown, invited me to lead a review to show how we could apply the recommendations of a global commission to one country, England. And I published the Marmot Review in 2010. So 2020 now was looking back. What had happened in the previous 10 years? And the simple answer is we've lost a decade, and it shows. What do I mean by that? This is what we're used to. This is life expectancy at birth. We're used to the idea that life expectancy increases all the time. We're getting healthier. I'd taken this back to 1980. Life expectancy was increasing about 1 year every 4 years for women and for men. I could take it back 100 years, and for 100 years, life expectancy was increasing about 1 year every 4 years. We were right to believe that health was always getting better. And then, 2010, something changed. Life expectancy increased, but at a much slower rate, and the improvement just about ground to a halt. What happened in 2010? Well, there was a new government elected, a Conservative-led coalition government. They said, you can't surely be saying it was anything we did that was responsible for this slowdown in improvement in life expectancy. Well, we need to look at it. I mean, one counter suggestion was, well, maybe we've just reached peak life expectancy. It can't keep improving forever. It's got to slow down sometime. So we looked at other countries. This is the annual life expectancy improvement in weeks between 2011 and 2017. Estonia, Norway, Slovakia, Hungary, Denmark, Belgium, Austria, Japan, Czech, Spain, UK. We had the slowest improvement of any rich country except Iceland and the United States. So no, we had not reached peak life expectancy. Something was going on in the UK that was much more extreme than was going on in other countries. And then we have inequalities. Classify people by where they live, and then classify where they live according to an index of deprivation, and divide that up into deciles, tenths of the distribution. Here's the most deprived decile, and indeed, poor people have shorter life expectancy than everybody else. But inequalities in health are not confined to poor health for the poor. Look at this. It's a gradient. The less the deprivation, the longer the life expectancy. In fact, if you're in the second top decile, you've got shorter life expectancy than in the top, for women and for men. It's a gradient that runs all the way from top to bottom. The gap between the least deprived and most deprived decile was 9.5 years for men, 7.7 years for women. And over the decade, that gap was increasing. The gradient was getting steeper. And if we look by region, this is women, for the least deprived 10%, it doesn't much matter which region of the country you're in. Life expectancy was improving gradually for all regions for the least deprived 10%. For the most deprived 10%, much bigger regional differences. If you're poor, the disadvantage of living in the northeast or the northwest is much bigger than if you're rich. And life expectancy was going up in London for the most deprived 10% and going down more or less everywhere else. So, before the pandemic struck in February 2020, health had stopped improving, inequalities in health were getting bigger, and life expectancy for the poorest people outside London was going down. Not a good situation. What could have happened? Well, in 2010, in the Marmot review, Fair Society, Healthy Lives, we had 6 policy objectives to address health inequalities. First, give every child the best start in life. Second, education and lifelong learning. Third, fair employment and good work for all. Fourth, really radical, in a rich country, everyone should have at least the minimum income necessary for a healthy life. 5, create and develop healthy and sustainable places and communities in which to live and work, including housing, and taking a social determinants approach to prevention. What do I mean by a social determinants approach to prevention? The NHS has an Eat Well guide advising people how to eat healthily. If people followed the Eat Well guide, for those in the bottom 10% of household income, they would need to spend 74% of their income on food. How can they possibly do that? For people who say poor people only have themselves to blame for their poor health, they could eat healthily, they don't have to eat rubbish food. No, they can't eat healthily. They'd have to spend 74% of their income on food. It's not poor people who are to blame for their ill health. It's their poverty that is to blame. This is what I mean by taking a social determinants approach to prevention. So, what happened? The government that came in 2010 had as an ambition, in fact, I think it was their only ambition, to roll back the state, austerity. And they did it. Public sector expenditure was 42% of gross domestic product in 2009-10, and that went down year on year to the 42% became 35% by 2018-19. And that reduction was done in what we call a regressive way. What do I mean by that? The grey bars are total local authority spending per person. For the least deprived 20% of areas, the cuts were extreme, but it was 16% cut in local authority spending per person. And then the greater the deprivation, the greater the cut. So in the most deprived 20%, local authority spending per person was cut by 32%. The greater the deprivation, the greater the need. The greater the need, the greater the reduction in spending. Could this have played a role in worsening health inequalities and slow down in improvement in health? Yeah, I think it could. It's credible. And the economic model didn't work. The supposed reason for doing it was to get economic growth. This was wage growth from 2007 to 2018, Greece negative, Mexico, and then the UK, and Portugal and Italy, and all the other rich countries got positive wage growth. So in the interest of getting the economy in good shape, apparently, we had these extreme cuts. Well, it didn't get the economy in good shape because we had negative wage growth. I won't go through all my recommendations from 2010, but we looked at them. So, for example, children living in poverty. Poverty is defined in a relative way. So it's living in a household at less than 60% of median income. In 2010, 18% of children were growing up in relative poverty before housing costs. After housing costs, that 18% became 27%. And over the decade, that 27% went up to 30%. Child poverty increased. Why is that important? Remember my first recommendation, give every child the best start in life. Do that, and over the life course, the conditions that lead to poor health will get better, will be improved. And the Chancellor, the Minister of Finance, changed the tax and benefits system. So if we look at working age families with children by income decile, if you were in the bottom 10% of household income, as a result of changes made by the Chancellor to the tax and benefit system, your income would go down by 15%. If you're in the next bottom decile, your income would go down by 12%, then 9%, and so on. The richer you were, the less the reduction. I sat with a former minister in the Conservative-led coalition government, said, your government's policy was to make poor people poorer. He looked a bit uncomfortable and said, perhaps it was not our explicit policy. Well, it was the absolute predictable effect of policy. And closure of various local authority activities. For example, support for youngsters. Could that be why violent crime went up? And it went up along the gradient. There's the most deprived, least deprived. There was a dip, and then up it went. So that was the situation in February 2020. I waited 10 years to do my follow-up report, and I waited only 10 months to produce the next one, which was the COVID-19 Marmot review, which we called Build Back Fairer. I showed you the situation. We don't want to go back to where we were in February 2020. It was far from ideal. If we look at mortality from COVID-19 there and all-cause mortality, so all-cause mortality, that's the other side of life expectancy, follows the social gradient. The greater the deprivation, the greater the mortality. It's really quite remarkable how graded that is. And there, the pale green is COVID-19. The social gradient looks pretty much the same for COVID-19 as it does for all causes of death. Now that's really interesting. COVID-19 is caused by a virus. Heart disease, cancer, chronic obstructive pulmonary disease, diabetes aren't caused by viruses. And yet the inequalities in COVID-19 are very similar to the inequalities in all causes. The same set of causes that I laid out, the Marmot 6. There's some excess in the bottom here, which we think is related to employment in frontline occupations, living in overcrowded, possibly multi-generational households. That was males, that's females. And then we have ethnic minorities. Black African, astonishingly high mortality in females and males. Bangladeshi, Black Caribbean, Pakistani. This is asking how much of that excess can be related to where people live, which in turn is related to deprivation. And you can see more than half is related to deprivation and to other socioeconomic characteristics. Not much to prior ill health for Black African and Black Caribbean. So more than half of the excess in Black African, Bangladeshi, Black Caribbean and Pakistani can be attributed to geography, deprivation and other socioeconomic characteristics. I was asked on the BBC, a minister said he was terribly concerned about ethnic differences and these people should wash their hands and practice social distancing. And I was asked what I thought. I said, that's good advice. And we should deal with structural racism. Structural racism that works in at least two ways. One is it increases the social and economic disadvantage of certain ethnic groups, and then may account for some of the excess that cannot be attributed to socioeconomic characteristics. In comparing COVID-19 with different countries, there's a problem because of the way countries assign cause of death. So one way of making the comparison is to ask how many deaths from all causes would we have predicted in the first half of 2020 based on the previous 5 years? And how many did occur? That's the excess. The excess in England was higher than in Scotland, higher than in Wales, higher than in Northern Ireland, and the excess in the UK was higher than in any European country. It was higher than in the United States, and the US was a disaster in 2020 in managing the pandemic. Our excess mortality was higher. So, to remind you, before the pandemic, life expectancy was stalling, inequalities were increasing, and life expectancy for the poorest people was falling. And that slowdown in life expectancy was nearly the slowest of rich countries. I think of health as a measure of societal success. If health was not improving, society was not improving. If health inequalities were increasing, inequalities in society were increasing. So that was the situation pre-pandemic. And then during the pandemic, we had the highest excess mortality. What's the link? I think it could work at 4 levels: poor governance and political culture, increasing social and economic inequalities, reduction in spending on public services. I showed you the regressive nature of the cuts to local government, and we were unhealthy coming into the pandemic. And then things only get worse with lockdown. This is teachers' ranking of how far their pupils had fallen behind. In the least deprived areas, pupils not behind at all, 1 month behind, 2 months behind. In the most deprived areas, 6 months or more behind, 5 months or more behind, 4 months. So there's an increase in the educational divide. If you look at working employment in a shut down sector, for those in the highest decile of earnings, maybe 5% were in a sector that was shut down, and the lower the earnings, the greater the likelihood of being in a shuttered sector. So either your workplace shut down, or you had to go out to work in a frontline occupation and be exposed to the virus. The pandemic wasn't all bad in the US. From March to December 2020, America's 651 billionaires had a growth in wealth of $1 trillion. You got that? That's $1,000 billion. A growth of 36% from 3 trillion to 4 trillion. They could write checks of $3,000 for each of 330 million Americans and be as rich as they were before the pandemic started. The historian Peter Hennessy, Lord Peter Hennessy, said Build Back Fairer is a beverage report for our time. You may not know about beverage. In 1942, during World War II, William Beveridge produced the Beveridge Report, which laid the basis for the welfare state, which was established at the end of the war. And Beveridge said there are 5 giants on the road to reconstruction. Want is only one of them, and in some ways the easiest to attack. The others are disease, ignorance, squalor, and idleness. I think it still applies. Want, we could say, is relative poverty. Children living in households at less than 60% median income. So relative poverty. Squalor, rough sleeping, poor quality housing. Ignorance, lack of education. Idleness, I would generalize and not just say unemployment, but the quality of work. And these all relate to ill health. So yeah, to the extent that Peter Hennessy is right, my Build Back Fairer report is a kind of beverage for our time. Remember, I said that health is a measure of societal success. I had a whole series of specific recommendations related to the 6 that I had in 2010. Give every child the best start in life, education and lifelong learning, fair employment, good work for all, having enough money to lead a healthy life, healthy and sustainable places in which to live and work, and taking a social determinants approach to prevention. But I think we need to address these things too. The quality of governance and political culture, the increasing social and economic inequalities, reverse the reduction in spending on public services, and deal with the fact that we were unhealthy. My recommendation to government is to put a fair distribution of health and well-being at the heart of all government policy.